European School of Oncology, e-session will start soon. Please hold on. Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 521,003. Good morning, afternoon and evening. This is the conference operator.
Guidelines and
The
pathways
European
of
School of
breast cancer care
Oncology
during the
welcomes you to
COVID-19
session
pandemic.
Good morning, please
Afternoon
afternoon and evening.
application to
This is
today's
the
session
conference
is
operator.
still in guidelines and
The European
pathways of
School of
breast cancer care
Oncology
during the
welcomes you to
COVID-19
session
pandemic.
Good morning, please afternoon and evening.
As a
This
reminder,
is the conference
the live
operator.
guidelines and
The European
pathways of
School of
breast cancer care
Oncology
during the
welcomes you to
COVID-19
Good morning, please
pandemic.
afternoon and evening.
As a reminder,
This is the conference
the live
operator.
guidelines and
The European
pathways of
School of
breast cancer care
Oncology
during the COVID-19
Good morning, please afternoon and evening. Good morning, please afternoon and evening.
Gustav Rusi, Good
Good morning, please afternoon and evening.
Gustav Rusi. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Cardoso. Doctor, your line is now open.
Good afternoon, everyone. So today we are going to call ourselves experts, though I think nobody's an expert in COVID-19 related to cancer, but we are trying to help everybody think a little bit and know how to deal better with this pandemic that is coming on. So this is a challenge, we know, and we know also that this has not ended. We are in the middle of pandemic, and many countries will pass through a raise in the cases they will have, and then we'll have to deal with everything that was left behind. So we want to help our colleagues to prepare themselves for this breast cancer care during the pandemic. What we know is, in spite of the pandemic, we aim at having in 2020 around, estimating the statistics of 2018, around 5 million new cancer cases in Europe, and they will still happen, and many of them will happen during this period. And we want to treat these patients according to what we think is the best possible scientific evidence. But in fact, we don't have many evidence regarding what we aim at doing during this pandemic, and we know that we have very low level of evidence in guidelines recommendations. Looking at what is published in PubMed in the 4th of April, now we are on the 7th, so this has changed already. We have regarding breast cancer and COVID-19 only 3 results. Cancer and COVID-19 134, and COVID-19 only 2,600 results. Many of the results regarding cancer and COVID-19 are recommendations from cancer societies regarding how to proceed during this pandemic. So we have very few evidence regarding what to do. What we know for sure is, and of course, we have more retrospective data than prospective data, then delays in treatment can have an impact on breast cancer-specific mortality and all-cause mortality. And this is mainly related to the time of chemotherapy, or either after surgery or in case of neoadjuvant chemotherapy, as you can see in the graph on the right. But also, starting of surgery and starting of radiotherapy can have this impact. So we need to worry how and when we are going to offer treatment to our patients. Regarding the evidence that we have in this COVID-19 pandemic and cancer patients, in fact, we have a very, very small evidence, and the only series that reports cancer patients during this pandemic in China, it has been published in the Lancet Oncology, and we have only 18 patients. And I think the most important result of this series shows us that even after adjusting for covariables that we know happens in our cancer patients, like age and smoking status, the cancer patients, when they get the COVID-19 disease, they are at more risk of having severe complications, an odds ratio of 5.3. So one of the things that I think will help most the people that are attending this session is to understand that we are not all in the same situation, although I think that probably the majority of us will be, but we are not in the same situation. And if you look at the European Center for Disease Control definition, you have the scenario 0, where you are in a country with no reported cases, the 1 and 2, what we call the contention phase. So we have introductions in the country by traveling, but limited local transmission. And then we have the scenario 3 and 4, where you have a widespread transmission of the disease, what we call the mitigation on emergency phase. So obviously, these 3 and 4 are the more serious phases, but we need to prepare ourselves, because once we start with the scenario 1 or 2, it's just a matter of time, because you'll be in the scenario 3 or 4. So what we are going to do today is we are going to discuss the possible options for healthcare professionals on how to deal with this COVID-19 in breast cancer patients that are either on ongoing treatment or are recently diagnosed with the COVID-19 regarding testing, and Pier Francesco is going to do it. And then we're going to share the recommendations between surgery, radiotherapy, and oncology. So, Pier Francesco, I hold the microphone to you.
Yeah. So thank you, and good evening, everyone. I will focus a little bit about testing in order to determine whether a patient is affected or not by COVID-19. So all the testing are based on nucleic acid amplification techniques. So for this, you will need an organic sample, which most likely would come from the lower respiratory tract or the upper respiratory tract. It will be mostly a swab, a wash, or aspirate, or sputum aspirate, and lavage in order to be able to obtain an organic sample to be tested for the presence or not of the SARS-CoV-2 virus. So how does the testing work? Basically, the testing is based on the polymerase chain reaction, which is a testing that is able to detect even very, very small amounts of the viral genetic material. And how to do that? By duplicating the genetic material many times through a complicated laboratory process, which is called amplification. So first, you will need a test sample to provide organic material by a swab in the posterior part of the nose. That will be able to extract small pieces of the viral genetic material, which will be engineered and will be linked to a primer, which will start the amplification process. And once the genetic material is amplified, there will be a fluorescent marker which is able to bound the copies of the genetic material which have been previously amplified. So basically you will have a positive result whether there is genetic material which will be amplified and which will be bounded by the fluorescent marker, or negative result if this is the genetic material, the viral genetic material is not present. So who to test? There's guidelines out there to outline the testing priority. So for sure, one of the priorities is to ensure the optimal care for the hospitalized patient and to lower the risk for healthcare professionals. So the first priority, of course, is to test hospitalized patient and to test healthcare workers with symptoms. But there's also a priority, maybe a lower grade priority, but still a priority for those who have a higher risk of infection. So patients who are in long-term care facility, elderly patients, so over 16 years of age, or patients with underlying condition should be tested. Lower priority, but still a priority for those working in critical infrastructure having symptoms, or for healthcare facility and first responders, or for individuals with mild symptoms. But what about cancer patients? Who to test and when to test? So we know that cancer patients have a higher risk of developing severe complication of infection, and specifically cancer patients are at risk if they receive anti-cancer type of therapy earlier on in the course of the disease. This has been shown in recent data published in the Annals of Oncology, where patients having an anti-tumor treatment, either surgery, radiation, or chemo, minus then 14 days before the occurrence of the infection, they would experience a severe complication of the infection. So cancer patients are at risk, and so theoretically, before starting a treatment, they should be tested. This is true for every type of clinical indication and therapy we are focusing on, but it's very true for surgery, which has organizational issue and should be treated in a safe and condition. So all patient undergoing emergency surgery should be tested for COVID-19, and of course, since the time setting is very, very short, we will need a rapid test. But also, patient planning to receive elective surgery should be tested in order to avoid infection and in order to avoid to operate on patient with a disease. But this, of course, has to face the availability of the test in the specific scenario. So this is very context specific, and also should be related to the timing to obtain results. So also this is context specific. So generally, patients should be tested, particularly if they need to undergo active treatment. But the way to testing and the timing and the specific scenario depends on the local characteristic of your clinical context of operations. So I will hand over again to Maria Joao for the continuation of the talk. Please.
Thank you, Pia. Okay, so we are now proceeding to the specific guidelines, and I'm talking a little bit about outpatient appointments and surgery and screening a little bit, because it's something very, very simple to address. But one thing that I've learned, and this is not evidence-based, is experience-based, is we need to prepare ourselves. That's the first thing, because even if you are in a very, very early scenario, if you have someone in your team that gets infected and you are not protected, you lose very easily 3 or 4 members of your team. So as Pierre was saying, if you have several tests and you have availability of testing everyone, it's quite easy. But if not, always protect yourself with all the protection that you have available and limit the exposing of your team. So split the teams to help to spare people to continue to treat cancer patients. So what is true now in a pandemic cannot easily be true tomorrow. So you need to adapt. So teams must be reduced to lessen the possibility. And for surgery, we have several constraints. One of them is due to careful disinfection of all procedures. The time interval between surgeries is much longer. We don't have laparoscopic surgery or robotic surgery, and this is also a controversy, but all the procedures that have diffusion of gases are complicated to work in these scenarios. So many procedures are technically contraindicated or need to be replaced. So in general, the recommendations for all the taking care of breast cancer patients, and breast cancer patients care is based on multidisciplinary decisions. We know that now we need to do the multidisciplinary tumor boards by web meetings, or if we don't have that facility, restrict the presence to one element of each discipline of the core team. That means medical oncologist, radiation oncologist, surgeon, and if needed, the imaging specialist. All decisions of the NDN should continue to be discussed with the patient, and the final decision must account for the patient preferences. Ideally, as Pierre said, we need to test all SARS-CoV-2, all patients for SARS-CoV-2 before surgery or any invasive procedure, and of course before initiating immunosuppressive therapies independently of symptoms. Many facilities don't have this capacity, so they need to rely on symptoms. And this is very important because the triage of symptoms is one of the main stays of this approach of the possible COVID-infected patient. If positive, the procedures of treatment should be resumed only after the patient has recovered, if possible. I just want to show you that we are proceeding, if this is already in press, recommendations for triage from the editorial prioritization and treatment from the editorial board of the breast that I hope will come out this week. So regarding screening, of course, screening can be delayed. The only problem is we need to track the patients that were proposed for screening. And this is very important too, because we risk to lose patients. So diagnostic of symptomatic patients need to be stratified. It's different if you have a suspicion of a DCIS or a cancer that has already lymph nodes that seems to be positive. All efforts should be made to avoid delayed diagnosis in those with suspicious symptoms. So this is very important because if we don't do like that, we are going possibly to have results of impact in mortality a year or 2 years later. So the outpatient visits replaced as much as possible by telemedicine. I think it's very important not to forget about the psychological impact of a diagnosis of a breast cancer. You need to try to use all the media that you have, like FaceTime, like Zoom, like whatever, to make the presence of the family of the patient next to you. Because in many facilities, the patient will only be allowed to be by herself, not with company. So it's very important. All follow-up appointments in stable patients need to be revised and possibly postponed, and prioritize appointments according to urgency, high priority, medium, and low priority. And these priorities are like this. So you have 2 weeks, between 2 and 4, 4 and 8, and 8 weeks, and these timings have been sort of used by all the societies. So if you have a patient that is pregnant and cannot go on chemotherapy, or you want to delay chemotherapy, you could operate the patient immediately. Patients with locally advanced not responding either to chemotherapy or radiotherapy, and patients with significant burden of disease not responding or progressing to primary systemic treatment. So in high priority, you have patients with early isolated local regional recurrence and high-risk patients with contraindications to primary systemic treatment. So younger, node positive, or disease showing biological features of aggressiveness. Medium, you have all the patients treated with primary systemic treatment that you should ideally operate at maximum 4 to 6 weeks after treatment completion. And premenopausal patients with small node negative tumors, but that you know that you cannot, as evidence-based, put on hormonal treatment for a long time. Low priority are all DCIS, except for the very large DCIS with hormonal receptor negative, and postmenopausal patients with luminal A-like cancer that you can put on aromatase inhibitor before surgery for more than 8 weeks without having them on risk. So to finishing surgery, the major points are you need to defer all benign cosmetic and risk-reducing procedures, offer outpatient surgery whenever possible, postpone all delayed breast reconstructions, minimize the use of oncoplastic procedures if they require prolonged and longer surgeries or have a high risk of complications, and in case of immediate breast reconstruction, if it is considered, advise easier procedures, more simple than microsurgery, autologous flap, and try to use more implants or expansions. So Pierre, again to you.
Yeah. So I will keep going, talking about radiation therapy. So as we say, like cancer patients are at risk of severe infections. So the idea behind the approach you need to have for radiation therapy is to try to decrease patient access to radiotherapy facility as much as you can. So a good strategy that has been pointed out by Nicholas Zahorsky, so US authors, is this acronym, which is RATS. So try to enhance in your department remote visits, so the use of telemedicine in order to replace the in-person visits as much as you can. So use smart working also, for example, for the medical physics part or for the follow-up visits. So whenever radiation is avoidable, and there are specific contexts in breast cancer where radiotherapy could be omitted for low-risk patients. For example, radiotherapy should be omitted in this critical situation. There are specific clinical scenarios where radiation could be deferred to a later stage, so it's not urgent right now. It could be deferred to a later stage where a less critical situation is present. So whatever is deferrable and in terms of clinical indication should be deferred. And whenever radiotherapy is indicated, hypofractionated, so shorter schedules, shorter regimen should be employed in order to decrease the frequency of patient access to the radiotherapy facility. In this situation, another acronym which is quite useful in terms of like general strategy is this PCOC: prepare, communicate, operate, and compensate. So prepare means that from a logistical, organizational, even physical point of view, your department should be prepared to face the pandemic, to face the critical situation. So, for example, you should like lower the total amount of treatment that are indicated in your and performed in your department. You should be able to organize your staff accordingly. You should separate functional units in order to decrease the likelihood to get infected. It's also very important to communicate with patients and communicate with the staff in order to share all the decisions that are taken in order to, that will make the whole process more easier. Operate is very important. All the staff and all the patients should operate in safe conditions. So everything, the operational point of view of the department should be run thoughtfully, carefully, and safely. And so operation in safe condition is very important. And the compensation for everything is delayed should be implemented to be able to compensate for delay of treatment from a radiobiological perspective. So specifically for the scenario 1 and 2, so where the transmission is limited from in a local point of view, and the cases reported in the country are limited. So the urgency is indicated by those clinical scenario where for example, the continuation of treatment which are already started, the palliative treatment which are not responding to medical treatment, and for example, acute spinal cord compression with symptoms. These are urgent situations and they should be treated as urgency. High priority situations are, for example, postoperative radiation for high-risk patients or for patients on treatment who have symptoms. Medium priority, all the postoperative scenarios for intermediate risk patients. For example, the consultation for patients who have post-treatment complications, and the treatments in the palliative setting which are responding to medical treatments. And low priority, whatever is referred to low-risk patient should be considered as low priority. For scenario 3 and 4, where the outbreak is a little bit more consistent, and so it sustains a widespread human-to-human transmission, or where in scenario 4 the whole healthcare system is overburdened by the referral of infected patients, the only urgency should be targeted to acute spinal cord compression with symptoms. High priority is the patient who already started the treatment and need to continue the treatment. It is highly recommended to consider the shortening of the regimen using hypofractionation. Palliative treatment not responding to medication, and the acute spinal cord compression without symptoms. Medium priority is the postoperative radiation therapy scenarios for high-risk patients and patients on treatment with symptoms. And low priority is everything else. I mean, postoperative scenario for intermediate risk patients, palliative treatment who are responding to medication, postoperative visit for complication, and follow-up for high-risk patients. This should be considered low priority for scenario 3 and 4. So there are, we say the acronym RAS. So we know that radiotherapy could be omitted for specific clinical scenario, and in this critical situation, radiotherapy could be omitted for example, low risk DCIS after breast conservation, also for infiltrative disease, for elderly patient with luminal A disease, small size, no negative. Those are scenario where radiotherapy could be easily omitted in this critical situation. And after mastectomy, for example, the small tumor with like a limited axillary involvement, as for the trial design of the NSABP B51 trial could be potentially omitted. This is a nice prioritization in terms of like the clinical priority for a clinical indication for radiotherapy to be placed. So high priority for breast radiotherapy should be targeted to inflammatory breast cancer, for example, for patients who have primary systemic therapy and have residual node disease in the axilla, or for a post-surgical scenario with positivity of 4 or more axillary lymph nodes, for recurrent disease, for not positive triple-negative breast cancer, and for patients with extensive lymphovascular invasion. Intermediate priority should be referred to patients with hormonal receptor positive disease with nodal involvement, for those having a pathological complete response in the axilla after neoadjuvant chemotherapy, for focal lymphovascular invasion, or for example, for triple-negative breast cancer with node negative axilla. All the other cases, luminal A disease, early stage disease, for elderly patients, luminal A disease, DCIS, they have low priority for breast indications, so potentially they could be deferred at a later stage after the critical situation as passed. Whenever radiotherapy is indicated, the main strategy is to lower the access of a patient to the radiotherapy facility. So the use of hypofractionated schedule or accelerated schedule should be enhanced and fostered somehow. So whenever there's an indication for partial breast irradiation, the suggestion is to use shorter schedule. For example, the Florence PBI schedule, which deliver radiation in only 1 week. For example, when whole breast radiotherapy is indicated, the UK Fast Forward trial or the UK FAST trial, so where radiotherapy is delivered to the whole breast in 5 fractions, either delivered in 1 week or in 5 weeks, once a week, could be a reasonable choice in this situation. Post-mastectomy radiotherapy, which most of the time is delivered in conventionally fractionated schedule, could be delivered using a hypofractionation in 15 or 16 fractions, and the same could be done for regional nodal irradiation, either after mastectomy or breast conservation using 15 fraction, the UK Star B regimen, or 16 fraction as the Canadian trial. So generally the idea is to shorten the duration of radiotherapy to decrease the frequency of access of the patient to the radiotherapy facility whenever radiotherapy is indicated. So I will hand over to Barbara, I think, if there's no question for the systemic part.
So I will focus my presentation on some decisions that we might be asked to take in these difficult circumstances, especially for patients that are receiving systemic therapy for breast cancer. Our objectives, just as a reminder, are to ensure appropriate cancer care for our patients with breast cancer, both early and metastatic breast cancer, while maintaining patient protection as much as possible, especially because breast cancer patients, such as the other patients with cancer, can develop some complications due to the infection with COVID. We can, to obtain these objectives, I think that we can consider some general recommendations and some specific recommendations that derives from the experience, from the Chinese experience, the Italian experience, and more recently from the French one. Considering that the general recommendations are all the recommendations that we need to put in place in our oncology department for all patients that are receiving a systemic treatment for cancer. And these recommendations are focused on minimize the presence of the patients in the hospital. So as first, we need to encourage patient management at home. We need to replace in-person visits with the telemedicine and phone calls. Whenever possible, we need to replace intravenous drugs with oral drugs, and moreover, to promote home administration of intravenous and subcutaneous treatment. Of course, we need to consider to change some chemotherapy frequency administration, favoring treatments every 3 weeks rather than weekly administration. And whenever possible, also to consider a temporary treatment interruptions, especially for patients with slowly evolving metastatic cancer. Of course, all these decisions must be discussed in the multidisciplinary team and shared with each patient. In the general recommendation, when the risk of infection in hospital is quite high, we need to consider select patients to be admitted to the hospital, and to select the patients, we need to use some specific criteria. As first, the curative or non-curative intent of treatment, the age of these patients, because we know that the patients older than 70 or even 60 are at higher risk of developing complications from COVID infection. And we need to consider, of course, patient's life expectancy. In the bottom of the slide, you can see a proposal in terms of a priority order. So you can see as first patients with curative intent treatments younger than 60. Second, patients with non-curative intent treatment back in first line. And as third, patients with non-curative treatment but with a rapidly evolving and symptomatic cancer that needs to be controlled by systemic treatment. This is just a proposal, and of course, the decision is at the discretion of the referring clinician. In the general recommendation, we need to consider also to improve all the measures to prevent patient infections in the hospital. So, to put in place daily phone calls to check the symptoms of the patients with treatment planned for the following days. To use appropriate separation measures in the hospital, to avoid as much as possible the presence of caregivers, to provide, whenever possible, surgical masks and hand washing with the hydroalcoholic solutions for all patients and staff members at the hospital entrance, and of course, to use as much as possible virtual multidisciplinary team and internal meetings. So I move now to the specific recommendation that concern more specifically patients with breast cancer. And I would like to start with some consideration about adjuvant and neoadjuvant endocrine therapy. As already mentioned by Maria Joao, we can and we need to consider to more largely adopt neoadjuvant endocrine therapy this time, especially for patients older than 70 with the relevant chronic comorbidities and with the HR-positive low-grade breast cancer in order to postpone surgery. Concerning the starting or the continuation of adjuvant treatment, it can be performed as usual, but of course we can monitor side effects of the treatment by phone calls and telemedicine visits, and delay all the imaging procedures that are not urgently required, for example, a bone density scan. Concerning adjuvant and neoadjuvant chemotherapy, we can select treatments with less hospital administration, with treatments, for example, treatments every 3 weeks instead of weekly chemotherapy. We need to limit the use of corticosteroids with chemotherapy because of the risk of immunosuppression. To prefer home administration of subcutaneous trastuzumab, for example, for maintenance dosing, use GCCF for intermediate risk of neutropenia, so even with chemotherapy at intermediate risk of neutropenia. And we can consider the delay of adjuvant chemotherapy for all the patients with HR-positive breast cancer at high genomic risk, but with the presence of comorbidities such as cardiac, respiratory disease, or diabetes. Considering patients with advanced breast cancer, of course, we can discuss case by case by evaluating the risk-benefit ratio. If we can put in place a delay of the treatment or replace the treatment with oral drugs, we need to use also in this case GCCF for the risk of neutropenia, and it's of utmost importance to inform our patients to stop oral chemotherapy in the case of suspicion of COVID infection because of the presence of infection symptoms. I would like to make some consideration also concerning target therapy and immunotherapy. I think that we need to discuss case by case whether to continue or not treatment with everolimus due to the risk of pneumonitis and the risk of immunosuppression, of course, related to everolimus. We need to adapt the dose of CDK4/6 inhibitor in order to limit as much as possible the risk of neutropenia. And of course, we need to adapt the dose of PARP inhibitors in order to reduce the risk of anemia, grade 3 anemia, that requires transfusion, blood transfusion in hospitals. And finally, we can also consider a treatment interruption for patients receiving immunotherapy with the CDK4/6 inhibitors, especially if the patients are experiencing a long-lasting complete response or partial response, or we can consider to delay the dosing of immunotherapy, also taking into account that this type of treatment has a long half-life. Concerning supportive care, of course, we need to implement home administration of all supportive care, and we can provide for all breast cancer survivors physical sports activities, recreational activities by using web platforms, and we can provide psychological support that is of most importance this time by phone calls and telemedicine. We need to remind that our patients are experiencing now a high level of stress, and they need our support and sometimes psychological support to better face with lockdown and social distancing. About breast and body imaging, I would make some rapid consideration. As first, we need to avoid as much as possible the use of CT scan because it's largely required now for managing patients with COVID infection. We might to consider to reduce also reduce the use of MRI because of the risk of device contamination, and also we consider to delay echo and MUGA scan for patients on anti-HER2 treatments, not at baseline, of course, but during the treatment, if the patients are not experiencing any symptoms, any cardiac symptoms, and are not experiencing FVG reduction. I would like to end up my presentation with some consideration, some focus about clinical trial participation, because of course in this time of facilities requisition in the hospital for managing patients with COVID, we need to limit the patients' accrual in ongoing trials. But I think that we need to discuss the case by case the accrual of patients in trials with the new effective treatments that can be a big chance for our patients, especially when they don't have any valid alternative. We need to consider also the possibility to refer on study patients to other active centers if we have some issues with the hospital organization due to the COVID infection. And also for patients in clinical trials, we can replace in-person visits and research nurse visits with phone calls or telemedicine. we need and we can implement the teleworking for all our research member staff, and we can, of course, delay all the on-site monitoring visits or replace them with remote monitoring. I really agree with the sentence reported by Matteo Lambertini and colleagues in the publication. In this time, more than in other time, I think that we need to preserve both scientific validity of our results and, in the same time, the safety of our patients and trial staff. Thank you.
So thank you. I think this was a great presentation, and I think I would move right on to the questions that our participants are posing. And I'm going to ask to each of you a set of questions that are mentioned by our participants. So first, to Professor Cardoso. One of the participants, a radiation oncologist for Romania, asks if you would consider to postpone surgery in cases of patients with complete response to neoadjuvant treatment, and if so, for how long, and would subtype impact this answer?
Okay, thank you, Ines. It was passed briefly because we wanted to tackle every point and it's not possible. But of course, having a complete response is a good prognostic sign, but we don't at the moment have evidence to don't do surgery. The question is, if you have all your operating rooms full of ICU patients, you need to think otherwise. Of course, if you are with a triple negative cancer patient, I think you need to go on. But if you have a hormone receptor positive, a luminal B patient that responded quite well, and it has either HER2 positive or HER2 negative, but you can prolong the treatment with hormone treatment or anti-HER2, you can just off balance your needs. So it depends on what you are available. For us, having surgery after primary neoadjuvant chemotherapy is always a medium priority. It means that you should do it after 4 to 6 weeks, not to lose the benefit of the treatment you had before. But this will depend if you are in an emergency state.
Of course. Now, Professor Franco, couple of questions for you. Some I think you already addressed, but maybe you can add something else if you think you should, and other more specific questions. So one, which type of e-fractionation would you use or do you use in your clinical practice?
Okay. So yeah, thank you for the question. So basically, since like 10 years, I would say hypofractionation is considered standard practice, I would say, at least in Europe, because we don't have issue for reimbursement after breast conservation. So normally the STAR P or the Canadian approach, so meaning 15 or 16 fraction over 3 weeks is the standard. Recent trial, particularly the FAST trial and the fast forward trial, try to contract to shorter even more the schedule. So you're using delivering 5 fraction, either given in 1 week, STAR forward approach, or in 5 weeks, once a week, the fast approach. So we don't have robust and mature data. The data of the fast forward trial are about to to be published, but still we don't have data. So the normal practice would be the 15 fraction or 16 fraction, but in this critical situation, I think that the 5 fraction over 1 week or over 5 weeks could be a reasonable proposal in order to decrease the frequency of admission of the patient to the radiotherapy facility. So that's what we're using now. After breast conservation, we use the 5 fraction given in 1 week or 5 weeks, depending on patient choice. It's a little bit different for postoperative radiation after mastectomy. So there, the evidence for hypofractionation is a little bit less robust than after breast conservation. But I think the 15 fraction, particularly the English regimen, can be used in this scenario, particularly if the patient doesn't undergo reconstruction. For unreconstructed chest wall, the 15 fraction are a good choice for sure. And hypofractionation could also be used for regional nodal irradiation. So the 15 fraction, either after breast conservation or mastectomy, whenever there's the need to irradiate also on the regional nodes, meaning the superclave and the axillary apex and the internal mammary nodes.
Following that comment, do you think we can use hypofractionation in the post-mastectomy setting if the patient had initially a T4 ulcerated cancer?
So this is post-mastectomy, maybe after neoadjuvant chemo, mastectomy, and so post-mastectomy radiotherapy for a chest wall. So I would go for hypofractionation. I don't have a particular issue. If you think about the hypofractionated schedules from a radiobiological point of view, they tend to be more gentle to normal tissue than compared to the conventional fractionation. So particularly if the patient is now reconstructed, I would definitely go for hypofractionation to irradiate a chest wall after mastectomy. And I wouldn't have a particular issue also in irradiating the nodal volumes. For a T4 case, I would even if using hypofractionation or conventional fractionation, it's very critical not to underdose the skin and the subcutaneous part of the volume. So I would definitely use a bolus. But this is like a technical issue, which is true either for conventional fractionation and for hypofractionation.
Okay. 2 other questions for you. So what about if in the middle of your treatment, regular standard radiation treatment scheme, the radiation center is totally overwhelmed, contaminated, probably eventually the entire radiotherapy service, or there is an important proportion of the health professionals that are out because they are sick. Do you would you switch in the middle of a treatment plan from a standard dosing to a hypofractionation dose scheduling? Would you add extra fractions to compensate doing half-half? What do we do?
It's complicated. I don't think there's enough evidence to suggest from an evidence-based perspective anything. I mean, we should act according to a clinically reasonable perspective, right? So for sure we have the option of compensation. So if we are experiencing a particular critical situation and we are overwhelmed actually by the infection, we have staff shortage, and then we cannot run the department anymore, then we can reasonably postpone the treatment. I mean, we can interrupt the treatment for a certain amount of time, a week, for example, in order to be able to try to find solution for the critical situation, and then we can compensate thereafter, adding extra dose, and we have all the radiobiological knowledge, and we can do calculation to be able to compensate. If a treatment is particularly cogent and very critical, for example, highly proliferating tumor, head and neck cancer, some lung cancer or cervix cancer, let's say if we still are able to continue the treatment and we want to continue the treatment, then we can, of course, it's very important, of course, to shorten as much as possible the treatment in order to face the situation, and there we will need to switch from conventional fractionation to hypofractionation, so we would need to do radiobiological calculation. So I think that's not the optimal choice. I would rather stop the treatment and compensate thereafter instead of like changing the fractionation. That adds a little bit more uncertainty to the whole radiotherapy delivery process. So
okay, last question for you. So if you have a patient in LINAC and he happens to have COVID, is tested, is symptomatic, he tested positive for COVID, would you continue radiotherapy? Do you stop? When do you resume?
Okay, this is like complicated. So the general indication, if a patient turns positive, is to stop the treatment, because of course it's a risk for all the other patients, for all the staff in the department. But it really depends on the clinical situation. So how high is the priority for the treatment to be continued? And it really depends also on the context, on the environmental scenario you have. So if for example the treatment is highly crucial, so the patient from an oncological perspective really needs to continue being treated, and at the same time you're very well organized, you're not in staff shortage, for example, you organize all your stuff like accordingly, and all the safety requirements are maintained in that specific situation. So high level of priority from a clinical perspective and very good organization, then I could like continue the treatment. Otherwise, if the treatment is not that is like medium to low priority, and the whole environmental contact is a mess, then probably I would stop the treatment. So it's really case specific, I would say.
Okay. Now, Dr. Pistilli, one question. You mentioned that you would consider adjusting the dose of CDK4/6 inhibitors. What do you exactly mean by this? Are you starting patients at a lower dose? Are you increasing the interval dosing? What are you considering? What do you mean?
Thank you, Ines. I think it's a very tough question because we don't have any specific data about patients receiving CDK4/6 inhibitor and the risk of complication from COVID-19. But we need to consider that patients on CDK4/6 inhibitor are at high risk of neutropenia. We know from the clinical trials that risk is around 60-65%. So in this specific scenario in which we are finding now, and especially in the scenario 3 and 4, in which there is a high human-to-human virus transmission and a high pressure on the healthcare system, I think that we need to protect also these patients that are receiving this kind of treatment. So to give you some example, if I have a patient on CDK4/6 inhibitor that are used to have neutropenia at each cycle, I think that I would consider to reduce the dose of the CDK4/6 inhibitor for these patients. For example, if she's on 125 of positive, I would reduce to 100 or even at 75. at least for the time of the health crisis, to be sure that the patient is not going to remain on neutropenia for a long time, and that means to be at higher risk of developing complications from COVID infection. If I have any patient that needs to start the treatment with CDK4/6 right now, if the patient is in a young patient with good clinical conditions, if it's patient, I would start at a standard dose, of course. On the contrary, if I have in front of me a patient that is older than 70, in this specific time, I would consider to start at a lower dose and to increase the dose accordingly to the evolution of the crisis.
Okay. Another question. So you have a patient on chemo, on adjuvant chemo, and she has an infection, a documented infection. When do you consider restarting the chemo? And what do you do if you do or not do any testing to restart the chemo?
If I understand well, we have a patient that has a suspicion of infection from COVID.
That has a documented disease.
Okay, with the documented disease. In this case, we need to stop, of course, the chemotherapy or the restart of the chemotherapy should be done at least 1 week later, the complete disappearance of all the symptoms. These are the data that we have so far. Of course, we don't have so much data about this again, but the majority of the evidence that we have can guide us toward this direction. So to restart the treatment at least 7 days later, the complete disappearance of all the symptoms.
Okay. Does anyone of the presenters has any remarks, want to add something to the discussion? This was a great talk. I think it helps all of us that take care of breast cancer patients to tomorrow feel that have more resources to take good care of our patients. But I would give you the word if someone has something else to add.
I think just to remark something that we didn't talk because it's not something that we use frequently, but I think it's coming out. That are the serologic tests that will help us, because when we are, for instance, as Barbara said, you are in the middle of chemotherapy or radiotherapy and then you need to wait. And we know that these PCR tests, we need to repeat them two times until the patient is negative or only rely on symptoms. And these serologic tests are quite quick to do. And I think they will help us a little bit. I don't know if you have any experience with them.
We don't have yet. No, I don't know if Professor Franco has.
No, I do not. Sorry.
Okay, we start doing them.
Dr. Pistilli, I
don't have any experience.
Yeah, because it's done like we started doing them this week. It's very quick. It's obvious that not all the patients have IgG antibodies quickly. So some patients take more time to develop the IgG antibodies. But it's easier because, as Dr. Francesco said, it's easier than do the smear of the nose and the throat than doing this because it's quite quick. But
this means that in your institution, if someone has a documented disease, where before it resumes chemotherapy, let's say, the rule now is to have IgG positive.
It's not the rule, Inês. Now we still need to have a test that doesn't show COVID-19. The problem with these serologic tests and the COVID-19 negative tests is that we have false negatives, and sometimes we don't have virus enough in the smear to have a positive test, and these are more reliable in terms of the change in immunity of the patient. That's only why. And I think at the moment, what we have, majority of places in the world. So in Portugal, we have some recommendations from the National Health Service saying that we need to test every patient proposed to surgery, and we need to test every patient proposed to chemotherapy or other systemic treatment, and we need to test every patient proposed to radiotherapy each week. It's not, we don't have tests for everybody to do that. So I think my message is we are going to have new tools. For the moment, I think for those who don't have tests to test anyone, and if the patient is obviously asymptomatic, that can represent a problem for equipment, for health professionals, and for the patient herself, we need to protect everyone very, very toughly.
I think for sure it will be a great resource. Just to end on that note, quick question, we have 1 minute. What is your practice for each of you regarding the testing prior treatment? Does everybody is testing everyone before surgery? Are you testing everyone every week after that is having radiotherapy? Are you testing in your institution everyone before starting chemotherapy?
In my institution, we are testing everybody before each treatment. So
Dr.
surgery,
Pistilli.
radiotherapy, and chemotherapy.
Dr. Pistilli.
Yes, in our institution, we are testing all patients with a planned surgery, of course, and we are testing only patients who are receiving any kind of treatment, chemotherapy, target therapy, or hormonal therapy, that have symptoms, so that have suspicion of the COVID infection. And those patients, even patient survivorship can be addressed to our institution if they have any suspicion of the infection. But we are not testing patients without any symptoms who are receiving a systemic treatment or a radiotherapy.
Dr. Frank, Professor Frank.
For ourselves, actually, I think we are in scenario 4 right now in my area where I work. So we only rely on symptoms. So we basically tend to test whoever has symptoms, but whoever is asymptomatic doesn't undergo testing, whatever procedure he needs to undertake, just because we cannot do it.
Okay. All right. So this was a great session. Thank you, everybody.
Thank you.
And for the participants out there, if you want to send us out questions even after this session, please be free. Thank you.
Thank you.
Thank you, Ness.
Bye-bye.
Bye.
Thank you, Dr. Cardoso, Dr. Pistilli, Professor Franco, and thank you, Dr. Vaz Luis. Ladies and gentlemen, the session has now concluded. The next e-ESO session will take place on the 8th of April, at the same time. And Dr. Stefano Caffarotti, of the Bellinzona and Valley Regional Hospital, Bellinzona, Switzerland, Dr. Angelo Del Monte, of the Romanga Scientific Institute for the Study and Cure of Cancer, Modena, Italy, will discuss with Dr. Marco Ciano, of the Interdisciplinary Cancer Service, HRC Hôpital Riviera Chablais, Rennes, Switzerland. The following topic: COVID-19, oncological risks and guidelines. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.